Okay, stop talking amongst yourselves. All right, now, clicker, please work. Okay. All right. Autonomic nervous system. Why do we care about it? Obviously critical for survival. Regulates homeostasis and reproduction. Innervates secretory glands, salivary, lacrimal glands, sweat glands, all that good stuff. Innervates heart and blood vessels to control blood pressure and flow. Bronchi, the lungs, digestive, metabolic function, kidney, bladder, large intestine, rectum, and also sexual responses and genitals. Okay. Why do you, as a physical therapist, care about this? And what are we going to kind of focus in on? Is that it's regulation over cardiovascular respiratory responses, particularly to exercise, physical activity. So you have to have a good understanding of the role it plays in that, so you know how to respond to your patients who are displaying either normal or abnormal responses to exercise. And then, as you're going to be going over in pharmacology, if you haven't already, you'll be introduced or talking about drugs that primarily are used to influence autonomic responses, whether it's blood pressure medications, asthma medications, those kind of things. And you also understand then, based on how these work, the side effects that may occur with some of those medications. Okay. The autonomic nervous system, just like our somatic nervous system, has an afferent and an efferent component. So we just talked about the afferent part of our somatic nervous system just in the last few days and weeks is the sensory system, but we're going to be talking about the autonomic nervous system today as a whole, and it actually has an afferent component and an efferent component. When you hear the terms parasympathetic and sympathetic nervous system for autonomic, those are the efferent part, the activating parts. But there's an afferent part of that system too, so we'll briefly mention that. So the afferent part, sometimes you'll hear it referred to as a classification as called a general visceral afferent, GVA. So if you're reading other textbooks and you see this terminology like GVA or GVE, all they're referring to is the classification of the type of sensory or type of nervous system classification we're talking about. So general visceral afferents is the afferent information coming in from your viscera, from your autonomic type function going on in your visceral organs and so forth, blood vessels and visceral organs. And then, so like the somatosensory system we just got done talking about, it's called the GSA, general somatic afferent, okay? So, but this is the GVA, okay? And so this information is coming in from the spinal cord through the spinal nerve roots, coming in from T1 to L2, okay? There's afferent information coming into your spinal cord from your organs through those particular levels, T1 to L2, and then also in nerve roots coming in from S2 to S4. Also, your cranial nerves, and particularly cranial nerve 7, 9, and 10, also have afferent. They have a sensory function, in addition to an efferent part, but they play a sensory role. Okay, so that's how the information about your viscera gets into the central nervous system through those particular levels and those particular spinal nerves and cranial nerves. Then the efferent part, okay, the part that goes out to drive both sympathetic and parasympathetic function, okay? So the sympathetic division, the nerves going out to drive that are going to come out between T1 and L2 through those spinal nerves, okay? The parasympathetic division is going to come out of the cranial nerves, okay? So parasympathetics on each side of the sympathetic nervous system. So the cranial aspect of it is the cranial nerve number 3, 7, 9, and 10. And then the sacral portion is through those nerve roots S2 to S4. Okay, those are going to drive the efferent, or the GVE, general visceral efferent components. So we're going to talk about the sensory system, or the visceral sensory system here first, the afferent part. We have receptors, just like we had our receptors in our somatosensory systems. We have receptors that tell us about what's going on with our organs and our viscera. We have mechanoreceptors. They're going to tell us things about stretch and pressure, things that are in the atria of your heart, in the ventricles of your heart, carotid sinus, bladder, intestines that are telling us about stretch, how full they are, how much pressure is building up in those systems, and those are going to be your mechanoreceptors. Typically, those may be a mix of some free nerve endings, but also some little more specialized receptors too. But don't worry about any real depth on that. Just know that there's some mechanoreceptors that sense that. And we also have chemoreceptors. Chemoreceptors, which are going to be free nerve endings, okay, in certain locations within your viscera, are very sensitive to certain, chemicals or things like oxygen concentrations, hydrogen concentrations, especially are very important, or glucose and electrolytes throughout your system. They're going to help to send signals back to your central nervous system to drive changes in response to that. Okay, so you have the carotid and aortic bodies, which respond to oxygen levels within the blood. In your medulla, we have our respiratory sensors and some of our sensors that drive heart rate that respond to levels of hydrogen ions, CO2 concentrations, and the hypothalamus is sensitive to glucose levels, electrolyte levels for driving metabolism, eating, those kind of things. Okay? We do have pain receptors, so there are sort of free nerve endings that are nociceptive pain receptors within our viscera. That leads to some of the referred pain we feel, but also drives some sympathetic responses and parasympathetic responses in response to pain that help move our system to, alleviate that pain or give us signals about it. And then there's also thermoreceptors, because our autonomic nervous system is important for regulating, our heat production, our body temperature control, and so forth. So you have thermoreceptors that are going to give us feedback about what do we need to do to adjust that body temperature. So let's talk about how this actually then, once the receptor is activated, how does this information specifically get into the central nervous system to be processed? Okay, so we have our cranial nerves, 7, 9, and 10. So 7, 9, and 10. So 7, 9, and 10 are involved with taste and swallowing function. Okay, specifically, so you have the taste in the tongue, okay, which is 7 and 9 that help to mediate that. But also they also work with 7, 9, and 10 work together to help with coordination of swallowing, and also the sensory receptors you just have in the back of your throat, your soft palate, and so forth. You have to have those working normally to have this coordinated motion of swallowing to occur via autonomic control. Okay, and then you have your visceral information that is all coming in primarily from cranial nerve number 9 and 10 are bringing in most of the visceral information from your. Okay. So we'll talk a little bit more about that coming up. And those are all converging. Cranial nerve number 9 and 10 specifically converge on a nucleus in the brainstem called the solitary nucleus. The solitary nucleus is a sensory nucleus in the brainstem associated with those cranial nerves, which when we get to cranial nerves, we'll go through all that. But in the spinal cord, then we've got our sensory afferents coming in from T1 to L2. Okay, so T1 to L2 is bringing in sensory afferents from the viscera and trunk, and they get into the spinal cord and they ascend up the spinal cord. And then we also have in our spinal cord in S2 to S4 is we have the afferent component of the autonomic nervous system coming in from, bringing in mainly from the pelvic structures. Bladder, genitals, and lower colon is what's bringing in that afferent information. Okay. In the spinal cord from T1 to L2, that afferent information comes in the dorsal roots, just like our somatosensory information comes in those same dorsal roots. But unique in the S2 to S4 segments, that afferent information actually comes in the anterior roots. So not a huge clinical importance there, but just thought that was interesting. It actually comes in the anterior roots. Okay. So that's how it gets into the spinal cord or into through the cranial nerves. So it's going to go into those areas, and then it's going to be processed at multiple levels so that you have this central regulation of autonomic nervous system function. So we're going to go through just the different areas within our central nervous system that take that afferent information, process it, and then send a signal out to drive the efferent parasympathetic and sympathetic control regulation. Okay, so starting kind of top down. So cerebral cortex, what does your cerebral cortex have to do? Most of autonomic is automatic, right? We don't have any cerebral control over that, but we do have control over a few functions of our autonomic nervous system. And actually, if you practice, you can gain more control over your autonomic. That's where the whole mindfulness and, and meditation and so forth. There's people that you can actually develop greater control over your autonomic function. But we all have some basic levels without having to do a lot of training about that. Who's like the best example of that craziness is David Blaine. Some of the stuff where he can, hold his breath for, how many, 17 minutes or something like that, ridiculous, or stay 3 days in a block of ice and, just go through extremes. So there's a perfect example of somebody who's well trained is be able to regulate his autonomic nervous system through some conscious levels of control. But it's trainable. If you've seen like documentaries of him, it just takes lots of practice and lots of hard work, hours and hours of dedication. But so cerebral cortex, conscious control of bladder function. So you can choose when you want to go to the bathroom and when you don't most of the time. And actually, as a baby, as they develop, one of the reasons that they can't control that initially is because of the myelination process. That's why it takes, trying to get a child potty trained, some of it just depends on how myelinated their nervous system gets so they actually can develop that conscious control over their bladder, okay, over those sphincters. Same thing with bowel, okay? We can obviously choose and start and stop when we need to with that, if, most of the time. And then breathing, you can hold your breath, and you can if you can consciously hyperventilate if you want to, those kind of things. Limbic system is part of the cerebral cortex. That's deep to the cerebral cortex, I guess. Some of those deeper structures of the limbic system, cingulate gyrus, and so forth. The fornix, so those are all parts. Those also have intimate connections and with various centers within your brainstem, spinal cord, to influence autonomic function. Okay, so when you get really nervous or stressed about a situation, you might have your heart rate goes up, your blood pressure goes up. You get the butterflies. That's just your diaphragm doing a little bit of a flutter or quivering that makes you feel like you've got butterflies because it's, the increased tone that the sympathetic nervous system is sending to it. So limbic system will obviously influence your autonomic nervous system. It can be a powerful influencer of that too. So you as a physical therapist, if you can calm your patient down, keep them calm, or help them to be, utilize that to overcome things such as, influencing pain and so forth. And then the thalamus. The thalamus plays a role in autonomic nervous system, primarily as a relay of afferent information into the limbic system and cortex. So some of that autonomic sensation is coming up. Some of it does reach the cortex, about your whole body temperature. But a lot of it's going to the limbic system, okay? So, but it's got to talk to the thalamus first before it goes to the limbic system to be processed. Then hypothalamus. Hypothalamus is the big guy. This is the big master controller of most of our autonomic nervous system regulation. It receives information from the reticulohypothalamic tracts. So information coming in from your spinal cord, from those T1 to L2 and those S2 to S4, those they send up your spinal cord, okay, and they often go to your brainstem into the reticular formation. And then the reticular formation sends a pathway up to the hypothalamus called the reticulohypothalamic tract. So reticular formation, hypothalamic tract. It's going from the reticular formation up to the hypothalamus to be processed and for regulation. Okay. And here's all the things it does. Regulates cardiorespiratory, metabolic, water reabsorption, digestive, reproduction. It exerts control partially through the pituitary gland. So when we're talking about hormonal secretion, that influences lots of other functions of our body through the connections of the hypothalamus with the pituitary gland. There's also a descending pathway from the hypothalamus that goes down your spinal cord to communicate with your sympathetic and parasympathetic efferent control, okay? And that's via this pathway called the dorsal longitudinal fasciculus. So there's another fasciculus that's running down. It's really hard. It's a small little pathway that doesn't just stick right out you in the spinal cord, but there's an actual pathway running down from your hypothalamus down in the spinal cord called the dorsal longitudinal fasciculus. So it's kind of in the back part of the spinal cord a little bit, and it's running the whole length there, all the way down to S2 to S4. Midbrain, so we kind of cerebral cortex, hypothalamus, thalamus, now we're in midbrain. So There is an area in the periaqueductal gray. Remember the periaqueductal gray? We said that it also is influencing descending control of pain inhibition. It's one of its. It also has another function, and it's a relay center for micturition for your bladder. Okay, so it actually acts as a relay center for some automatic bladder control. There's also in the midbrain, there's a specific nucleus associated with cranial nerve number 3. When we get to cranial nerves, we'll see that more. We'll talk about that a little bit more, called the Edinger-Westphal nucleus. That is also right, it's in the periaqueductal gray, but it's right at the very front of it's kind of the very ventral medial part of the periaqueductal gray, right in front of the cerebral aqueduct. There's the 2 little nuclei there that have a couple little fibers that go out and supply some parasympathetic control of some smooth muscles in your eye, and also of your levator palpebral muscle for your lifting your eyelid just a little bit. So that's autonomic parasympathetic control there. But so pons is the next level down. So pons primarily involved with respiration. This is where your pneumotaxic center is. Okay, it's going to be sensitive to different levels of concentrations of hydrogen ions and CO2 primarily to help drive your respiratory. And it's also there's a micturition center within the pons too. And the periaqueductal gray micturition center communicates with the pons micturition center and working in coordination with your cerebral cortex. But all those working together influence normal automatic and conscious control of bladder emptying. Moving down to the medulla. So medulla plays a larger role in just regulation of heart rate. Okay, does also play some role in respiration as well, in conjunction with the pons, communicating with that. For swallowing. Okay, so your cranial exit area and some of this nuclei for cranial nerves that are coordinating the swallowing function are going to be in that medulla. Chewing, coughing, and also vomiting centers too, that cause us to vomit or the medulla region. The solitary nucleus, that's the one I mentioned. That's where a lot of information is coming in. Visceral information from cranial nerves number 9 and 10 are all coming in that solitary nucleus to be processed before they're sent from the reticulohypothalamic tract up to the hypothalamus for regulation and so forth. Then the spinal cord. Our spinal cord, we have actually, just like we have reflexes for our knee reflexes and so forth, we actually have autonomic reflexes. So we can drive some autonomic function just within our spinal cord reflexes at segmental levels. Okay, so. And this is also where our pathways for both getting information in about our, organs and viscera, and also getting it out is through those spinal cord. So this is just a nice quick schematic here showing kind of an overview that we have information that has to come in, tell us what's going on with our system, and then it's processed in all these different areas within the central nervous system. We drive responses based on that to an efferent pathways that are sympathetic and parasympathetic, as well as some hormonal release from things like our pituitary gland, also our adrenal medulla on top of our kidneys. So those things help drive our responses to maintain normal homeostasis and proper regulation depending on the environment we're in, or what we're doing, or the activity we're doing. So now, any questions on kind of the afferent part and the central processing part? It's just good to have a good overview and understanding of kind of how it's all integrated. Yeah. Do I have hormonal on that? Where are you at there? Oh, there's 2 separate things. Yeah. Then descending pathways is a separate thing from the hormonal system. So yeah. Did anybody else? Did you have another question? Just even reflex control of sweat and even blood vascular dilation and constriction at segmental levels for driving, control over, even response to movement, exercise, those kind of things. So, or to pain. you know, and so forth. You can have actually local responses and changes in autonomic function right at that spinal cord level. And that becomes a problem when we start talking about spinal cord injury, and we have this thing called autonomic dysreflexia, which is a going haywire of those spinal cord autonomic reflexes. They're too active, basically, kind of like we get overactivity of our knee-jerk reflexes with the upper motor neuron problem. You can have problems of dysregulation or control of those reflexes of autonomic functions. So. Anything else? All right, so now we're going to talk about the efferent part, the control part here, okay, of our sympathetic and parasympathetic systems. I think most of you guys have, you know, at least dealt with it a little bit in some physiology class at one point. So what is the difference between the somatic motor, which we're going to be talking about on Friday, which is, you know, conscious control of moving muscles, skeletal muscles, versus, which is called our GSE, general somatic efferent, okay, versus our autonomic efferent, also known as our GVE, general visceral efferent systems, okay. So this just shows you a little bit of a schematic here that's somewhat simplified. Showing you, here's somatomotor here, cell body is in the CNS, and where's that cell body for the that's an alpha motor nerve? What part of the spinal cord is that in? That'd be the anterior horns, where that is. That's where that cell body for that final nerve that's going to go out to a muscle, okay? So here's just showing skeletal muscle here, and we have a nerve that extends out, goes all the way from the central nervous system where it lies in that anterior horn, and the nerve goes uninterrupted to the muscle to deliver its signal, okay? In comparison, here's our autonomic efferents, sympathetic. In most cases, there's two neurons in these pathways, okay, for the autonomic efferents. For the sympathetic, you have a short, what's called preganglionic fiber, relatively short in most cases. There's a few exceptions. Then you have a longer postganglionic fiber that then goes to innervate basically smooth muscle, cardiac muscles, and glandular cells, okay, versus skeletal muscle. Then on the flip side here, on the parasympathetic part of the autonomic nervous system has a longer preganglionic fiber with the ganglion, okay, or group of cell bodies closer to the effector organ. So whatever it's going to drive, there's a ganglion out closer to the effector organ. Again, this is in most cases, not always, but in most cases. And it's also going to innervate smooth muscles, cardiac muscles, and glandular type cells, okay? So that's just a very simple schematic there. I included on your back of your packet kind of one of my favorite pictures, because I like simple. This one here is a nice picture, and I can't find the resource I got it out of to get a better copy. I looked for like an hour yesterday trying to find which resource I got this out of, and I looked on Google Images, and nope, not there. But this breaks down, starting here is the somatic motor, which is your, you know, what we're going to be talking about on Friday for skeletal muscle. Then it has sympathetic, parasympathetic, and it also talks about adrenal medulla, which plays a role in some sympathetic control primarily, but we'll show that to you. But it then also shows you the neurotransmitters, shows you the kind of the relative length of the pre and postganglionic fibers, you know, and then the receptors. Okay, so it's kind of all in one picture for you. A lot of what we're going to talk about right now is right there for you in one kind of picture. And your book has a better picture now in it than it used to. Let me see if I can, which I kind of like. Autonomic. This one right here on page 179, this does a pretty deep job of summarizing sympathetic and parasympathetic function, which including the neurotransmitters involved at each level, and also the general types of receptors that are used, that are those neurotransmitters bind to drive these different functions. So that's a decent, nice added chart to your.
What edition was that?
This is the 4th edition. Yeah, 4th edition. This is the latest edition. So page 179. So neurotransmitters that are used in autonomic efferent systems, okay? Under two major classifications, either cholinergic or antinergic, okay? If cholinergic, we're talking acetylcholine. If it's an antinergic receptor or neurotransmitter, it's going to be either a norepinephrine or epinephrine, are the two main adrenergic neurotransmitters used in this autonomic nervous system. So let's go through the cholinergic neurons first. Okay, so all of the preganglionic neurons in the autonomic nervous system secrete acetylcholine. Okay, that's the neurotransmitter they use to communicate with the postganglionic neuron. So that's easy to remember, that they all use acetylcholine. Okay, that first connection. Acetylcholine is also used at the postganglionic neurons of the parasympathetic nervous system. So parasympathetic postganglionic neurons secrete acetylcholine. Okay. The preganglionic, going back to that first bullet point, sympathetic and parasympathetic use acetylcholine are being secreted from those preganglionic neurons, those first neurons in the pathway, that first connection point. It's the second connection point here, the postganglionic neurons, when they're going to be connecting with their effector organ. Okay, parasympathetic primarily is going to be using acetylcholine. It's going to be cholinergic in nature. Okay. There are some sympathetic postganglionic neurons, specifically that innervate sweat glands, and some sympathetic postganglionic neurons that innervate vessels in skeletal muscle that also use acetylcholine. So there's the exception. There's a few sympathetic connections, postganglionic sympathetic fibers that secrete acetylcholine. And if you go by this chart back here, let me use yours so people can see here. If you go to here, to sympathetic here, and you go to that one on the bottom there, that's what they're showing there is the acetylcholine being secreted right here. That's that exception right there, and they're showing sweat glands there. If you want to write under sweat glands, also put arterioles, skeletal muscle. So within muscles, skeletal muscles, so under this little area that says sweat glands, and it has a little asterisk there, go ahead and put underneath that skeletal muscle arterioles. Also uses some acetylcholine binding specifically to the M, which is muscarinic receptors. That's the exception. Okay, most of them that do use are adrenergic nature, but okay, so. And that becomes significant when we talk about response to exercise in a few minutes here. So still on cholinergic receptor. Now we're talking about the acetylcholine being secreted, but then they fall on receptors, and depending on the type of receptor they fall on, that will influence the action that's going to happen. Okay? There's two groups of receptors that bind acetylcholine. There's the nicotinic type receptors and the muscarinic type receptors. If acetylcholine binds to a nicotinic receptor, it's going to drive a fast excitatory postsynaptic potential. Okay? So it's going to create some kind of action or activity that's going to drive a ligand-gated, fast opening of sodium channels or chloride channels or whatever channels to get that organ to do what it wants, to what you're attempting to do with that delivering that signal. Okay, fast excitatory postsynaptic potentials if it falls on that nicotinic receptor, or if that binds to the nicotinic receptor. If it binds to a muscarinic receptor, the muscarinic receptors tend to be G protein-mediated responses. So those are those ones where you get the G protein secondary messenger system that drives longer-lasting changes. Could regulate or regulate. It can create an excitatory postsynaptic potential or an inhibitory postsynaptic potential. So if it falls on the muscarinic receptors, the influence can be a little more complex, longer-lasting, and a little more modulated in nature. Okay. So that was cholinergic. Okay, neurons and the receptors. Cholinergic neurons that secrete acetylcholine and the receptors that bind acetylcholine. Okay. Now we're going to talk about adrenergic neurons and their receptors. So adrenergic neurons and receptors are the ones with Norepinephrine and epinephrine are your antinergic, neurotransmitters. But so where do these secreted? So most sympathetic postganglionic neurons release norepinephrine. Okay, so most of your sympathetic postganglionic neurons release norepinephrine. And on your picture here, it's this one right here. Right here. This is most right here. This is norepinephrine. NE. This is this first one here is what's is most commonly done. However, the adrenal medulla also plays a role in overall regulation of sympathetic function. And the adrenal medulla releases a kind of variant of norepinephrine called epinephrine. They have similar results. They both drive sympathetic responses. Epinephrine is just secreted into the bloodstream, okay, and it goes to your organs through the mouth and directly affecting them from a neuron, dumping a neurotransmitter right onto that effector organ. It has to go through your bloodstream, okay. So it's a little delayed, but it's also a little longer acting once it does get secreted, okay. But you do have sympathetic nerves that go to the adrenal medulla to tell the adrenal medulla to secrete the epinephrine into the bloodstream, drive some of that. Then the response will depend on what type of receptor that norepinephrine or epinephrine binds to. Okay, and we have two different groups of antinergic receptors. There's more, but the two major classifications or groups are either alphas or beta receptors. And we have alpha 1s and alpha 2s and beta 1s and beta 2 receptors that are antinergic, that bind norepinephrine or epinephrine or a combination. Some may be selective more to one than the other. And then these are located in different regions of our heart or bronchi or vessels in our body. And so that's going to really drive how those each respond when those are bound. So this is from your book as well. I don't know if this one is also in your fourth edition. This is from the third edition. This is just showing kind of that similar chart. The only thing I don't like about this, it doesn't show the receptors. It just says antinergic. It doesn't show all the receptor classes. And it shows all these being similar in length. So I don't like it because it doesn't show the longer, postganglionic receptor, with the, different classifications there. Shorter with sympathetic, longer with the parasympathetic. So that's the only thing I don't like about that. So we're going to go through the sympathetic nervous system, and then we'll go to the parasympathetic, and then we'll be pretty well done here. Okay? So sympathetic. Some people call it fight or flight kind of system. So it does some of that, but it does some other things as well. So going through the sympathetic efferent neurons. First of all, where are the cell bodies? Okay, so the cell bodies of the preganglionic sympathetic neurons, okay, are going to be in the lateral horn of the spinal cord, T1 to L2. We'll show you a picture of that in a second. So that cell body starts in the lateral horn of the spinal cord. It goes out the ventral root, goes through what's called the white ramus, which we'll show you in a moment here. It goes, most of the time, it goes into the paravertebral ganglia, which is this little group of ganglia or cell bodies that are outside, just laying right next to the vertebral bodies of your vertebrae, okay? And we'll show you a good cross-section where that occurs in a second here. It'll go up or down a few levels. It may ascend or descend a few levels before making a connection. That's most common. It'll make a connection right there, so you have a short preganglionic nerve fiber that goes and makes a connection in that paravertebral ganglia and then sends its longer postganglionic fiber out to the effector organ, wherever it's going to go. Okay. Some, however, will go straight through and not even stop at the paravertebral ganglia. They'll go right on out, and they'll actually make a connection closer to the target tissue, and that's specifically the celiac and mesenteric ganglia, which are down in your gut. Okay, so the gut are a little different, and it doesn't make a stop at those paravertebral ganglia in a segmental way. So most of our, sympathetic system has a lot to do with driving control of blood flow to our organs and to our tissues, and that's in a very segmental way. Those that are going to all your blood, driving blood supply and constriction vessels and dilation of blood vessels. Those are all at the segmental level, making those connections at those paravertebral ganglia before they go supply that region of your skin, muscles, to drive, you know, regulation of blood. But the part of the sympathetic nervous system going to your gut kind of bypasses that and actually makes a connection a little closer, so to the effector organ. Okay. If it makes that connection in the paravertebral ganglia, then the postganglionic neuron passes through what's called the gray ramus, and then into the ventral or dorsal ramus of the peripheral nerve to go to that region of the body to drive, vessel, constriction, dilation, and so forth. And I'll show you that in a second here. So let's follow this real quick here. So this is from your book. Here is that little lateral horn, okay? And you're only going to see that lateral horn if you get a cross-section in the spinal cord between T1 and L2, because that's the only place where those cell bodies are. If you're in the cervical spine, you're not going to see it. If you're L2 to S2, you're not going to see it, but you also see it again in S2 to S4. But that's where the parasympathetic cell bodies are located in the lateral horn. This is sympathetic right now. These are in the lateral horns between T1 and L2. There's a cell body. It goes out through the ventral root. Here's our spinal nerve right here where it joins together. The dorsal root and ventral root join together, and this is our spinal nerve right there where they come together. It goes out. If it's going to the front of the body, it's going to go supply blood vessels or muscles in the front of the body. It's going to go out through what's called the ventral ramus. This is this little branch right here. That's the ventral ramus. Then it's going to go through this thing called the gray ramus, make its connection, or may go up or down a few segments before it makes its connection in the paravertebral ganglia here. And then this is going to be exiting out what's called the white ramus, and then finally back out through either the ventral ramus or the dorsal ramus if it's going to go to the back of the body. If it's going to go to the back of the body, blood vessels and skin or whatever, to sweat glands, and to the back of the body goes out the dorsal ramus. So here's the example where it goes through and it passes right through and doesn't even stop at the paravertebral ganglia. It just goes right out to the gut, okay? Celiac or mesenteric areas. So here we are. Here we're showing you, this is that T1 to L2 region right here. There's the cell bodies lying in that lateral horn, and they either synapse with the paravertebral ganglia, or they, in the case of the gut, they might go straight through and make synapses closer to the organ, okay? Some of these will actually ascend. These ganglia, actually, there's a group of them are actually closer up into the cervical area called the cervical ganglia. And there's a superior cervical, a middle cervical, and a stellate ganglia. And this is where the connections are made for the sympathetic control of the face, okay, and head is where those are going to be up in that area. So it'll actually ascend up from T1 and T2 areas and ascend up and make those connections up in these cervical ganglia to supply facial areas with sympathetic innervation. Okay. So let me show you this kind of in a more realistic looking cross-section here. So this is a cross-section through a thoracic vertebrae, okay? And so let's point this out and we'll draw it. So here is, let's start here. There's a lateral horn. You guys see me drawing that there? Oh, what happened? There we go. You guys see the little red dot I made there in the lateral horn? That's where it's going to start. It's going to go out through the ventral root. Kind of follow me through the ventral root there. Ventral root. Wish I could make that a little wider. It's going to go, so there's the ventral root. This is your spinal nerve right here, right where it's together there. That spinal nerve then divides. Once it gets outside of the foramina there, it divides into a ventral ramus, which is actually going to go out to the front of the body, and this is the dorsal ramus going back to the back of the body, okay? So once it gets out of there, so this is ventral ramus, this is dorsal ramus, but then here's your paravertebral ganglion right here. This one right here is called the gray ramus, and this one more medial is the white ramus. So that neuron comes out, goes through here, goes in, so bypasses the white ramus, goes into the gray ramus, goes into the paravertebral ganglia, which are connected all the way up, and may go up or down a few segments before it makes a synapse in the paravertebral ganglia. And then the postganglionic neuron goes back this way through the gray ramus, and then it decides, am I going to the front of the body? If I'm going to the front of the body, I'm going to go out the ventral ramus. If I'm going to go to the back of the body, I'm going to go through the dorsal ramus to go supply the back of the body. And remember, once we're in these dorsal ramus and gray ramus and the spinal nerve, all this is mixed. There's motor, there's sensory, somatosensory, and autonomic function, in all these. Here's the ventral root, which is motor, dorsal root, which is sensory, but we also have some autonomic function coming in here. Here it's all mixed. So once they go out into those ventral ramus and dorsal ramus, that's going to either go to the front of the body for motor, autonomic, and sensory, or to the back of the body for motor, autonomic, and sensory function. Okay. So, basic functions of the sympathetic nervous system. Primary role, and the one you want to know most about, is its role in maintaining optimal blood supply to organs. Okay. Generally maintains some background vasoconstriction. So your sympathetic nervous system is on at a certain level all the time, and it's maintaining some background vasoconstriction of your vessels. Okay, primarily in your skin and also in some of your muscles, so that they're not totally open or totally closed. They're kind of in the middle, which makes it nice because then if you do need to open them, you can relax them and create more blood, or you can constrict them even a little further if you need to constrict them down a little bit. So you kind of keep it in that, like to keep the volume in the middle, so you can go either up or down. So they're maintaining some basal vasoconstriction, okay? If you stand up quickly, that activates the sympathetic nervous system to actually crank up a little bit and cause a little greater vasoconstriction briefly so you don't pass out, okay? That background vasoconstriction goes up with rapid changes in postural changes, okay? And that's actually mediated by some connections with the vestibular system and brainstem connections that tell that your body now is changing positions quickly or moving in an upright position. And some of the reflexes, spinal cord reflexes, that tell us, like if I get sensor information telling I'm putting weight on my feet and I'm getting in a standing position, there's actually reflexes that tell those vessels in my legs to tighten up a little bit because you're making a quick change in position here so you don't pass out. However, there's stimulation of different sympathetic efferents that can cause vasodilation of muscle during exercise. So we have the background vasoconstriction that's important for just maintaining normal blood pressure and changes in body position. But when I start to exercise, if I need blood to go to a certain muscle group, I need some vasodilation. So their sympathetic system also can cause selective vasodilation in exercising muscle. Okay. And we'll show you how that occurs with a little more complexity here in a second. So for and then also another big role is regulation of body temperature. Okay, so regulation or release of epinephrine by the adrenal medulla, that kind of just constant release of epinephrine at a certain level, will help to maintain a certain level of metabolism. But if I need to crank up the heat, my sympathetic nervous system will tell my adrenal medulla, hey, release more epinephrine in your bloodstream. That raises metabolism throughout your system and raises your body temperature. Okay, or vice versa, you can shut that down. Okay. We also, with the sympathetic nervous system, control blood flow to the skin capillaries, okay, and sweat. So if I create more vasoconstriction in my skin, I reduce loss of heat because I shunt the blood away from my skin and keep it to my core. So I can make myself warmer that way too, by causing more vasoconstriction of those capillaries in the surface of my skin. But if I need to cool off, I can also turn on my sweat glands and create sweat so I get evaporative cooling. I can cool down. So the sympathetic nervous system is very important for this regulation of body temperature. So now we'll get into a little more detail about the regulation of blood flow specifically to skeletal muscle, okay, especially during exercise and activity. So skeletal muscle arterioles contain both alpha and beta 2 antinergic receptors, okay? So they respond to norepinephrine, antinergic receptors, but there's also some muscarinic cholinergic receptors in those arterioles as well. And that's the one I told you to add in, that exception, okay, that I told you to add in on that little schematic you guys had. So this is what happens during exercise, or let's say, starting with the background changes in position, which we mentioned. The norepinephrine binding to the alpha causes vasoconstriction, okay? That's for the background changes, background vasoconstriction that you have. You have a little bit of norepinephrine being dumped out all the time, keeping a little bit of vasoconstriction. When you change positions, norepinephrine binding to the alpha receptors in your skeletal muscle causes more vasoconstriction, okay? However, when you start to exercise, and I'm running on a treadmill or whatever, after a minute or so, my body recognizes, hey, he's moving these muscles, his leg muscles are working extra. I need to find a way to get more blood supply to those muscles. So what happens is you start to release epinephrine from your adrenal medulla into your bloodstream. It takes a minute or two to get there. It gets to your muscles, and especially it will be absorbed in the muscles that are most active. And epinephrine binding to beta 2 receptors will now cause just the beta 2 receptors inside skeletal muscle to start to dilate and actually allow more blood to go to those muscles that are working, okay? And that also is combined with some innervation of those skeletal muscle arterioles with the cholinergic, okay, receptors that are binding, with the muscarinic receptors that are binding acetylcholine that also lead to vasodilation, specifically during exercise. So the combination of binding of epinephrine to beta 2 and also acetylcholine to the muscarinic receptor, those two things cause vasodilation of exercising muscle. Okay, so that's how we help to regulate. That's the sympathetic nervous system. Causes both vasoconstriction for the background stuff and position changes, but also can lead to vasodilation during exercise because of its interaction with those different receptors and the different neurotransmitters being secreted. Sympathetic control of the head. So we have sympathetic control of the body. We also have sympathetic control of the head. Very similar functions, for sweat, for background, for changes in vasoconstriction and dilation of blood vessels and so forth. So those are the same kind of function there. One other thing it does that's kind of special is it dilates the pupil. So opens up the pupil, dilates the pupil. It also innervates the smooth muscle portion of the levator palpebrae superioris muscle. So there's a little bit of few smooth muscle fibers in this thing that lifts your eyelid up and keeps your eyelid up. So we'll talk about a syndrome when somebody has a problem called Horner's syndrome. If there's damage to those sympathetic pathways to the head, their eye will droop a little bit because of the loss of function of that little muscle. It also innervates salivary glands. So when those are active and during a sympathetic response, it produces thick saliva. That's why your mouth feels, when you're nervous, it feels dry to you, but it's because your saliva is thicker. It feels kind of thickened up, and even though it's not really a dry mouth, it's that you're producing a thicker saliva that feels kind of gummy and not so wet. And then also innervates the sweat glands of the head and face. Okay. So people with this thing called Horner's syndrome, if it's on one side of their body, their pupil will be constricted, okay, because normally the sympathetic helps to dilate the pupil, so their pupil will be constricted. They'll have a droopy eyelid on one side, and they'll also they won't have sweat on that side of their face. If they get hot, you only see sweat. They'll only be sweating on the one side of their face. So it's kind of an interesting syndrome. Sympathetic nervous system, regulation of the visceral organs. So main thing, increased heart rate and contractibility of the heart. Increases the rate and the strength of contraction of your heart. And that's via norepinephrine binding to beta 1 receptors on the heart. it causes dilation of the bronchial tree, okay? And that's via norepinephrine binding to beta-2 receptors that are located in the bronchi. Then from a standpoint of sexual function, sympathetic control is important for the process of ejaculation, okay? And when we get into spinal cord injuries, different levels of spinal cord injury, we'll get into more depth on how sexual function is impacted by damage to those different sympathetic and parasympathetic pathways in the spinal cord itself. Any questions on sympathetic nervous system and control, especially during exercise, and how we get more blood to those exercising muscles? All right, we're almost done here. We got to get you guys. What time is your class at? If I run like 5 minutes late, you're okay? Because you have first class like at 10:30. Okay, so I might just run like 5 minutes late. Parasympathetic nervous system, cell bodies in brainstem or spinal cord, S2 to S4. So in the sympathetic, it was T1 to L2 were those cell bodies. This is just located S2 to S4 in a lateral horn again. The ganglia are separate and near the effector organ. So instead of going to these little paravertebral ganglia, they go farther out towards the effector organ into these special areas. It's also known as the craniosacral division of the sympathetic nerve, not the sympathetic, of the autonomic nervous system. So because it's got a cranial nerve component and that sacral component. Okay. So the cranial nerve component that drives parasympathetic function is through the efferent part is cranial nerves 3, 7, 9, and 10, with 75% of all your parasympathetic fibers coming from the cranial nerves through cranial nerve number 10, the vagus nerve. The vagus nerve is the big driver. Okay. The sacral part, okay, so we have the cranial part, which is those cranial nerves. The sacral part, the cell bodies are in the lateral horn, gray matter, S2 to S4. Those are primarily going to your bladder and genitalia. Is primarily what those parasympathetic control of those. So here you can see, here is our cell bodies associated with the cranial nerves that are going to drive parasympathetic control of the head and face. But also here's the big one. Here's cranial nerve number 10. You see it innervates everything else. So that's why 75% of those fibers, cranial nerve number 10. Okay. And then here's just the S2 to S4, primarily involved with bowel, lower rectum or colon here, bladder and genital function, sexual function. Parasympathetic nervous system function, primary function is energy conservation and storage. Okay. Decreased heart rate and contractility. Bronchoconstriction. Okay, so constriction of the bronchial activity. So mostly the antagonistic to sympathetic function. Increased digestive activity, glycogen synthesis in the liver, glandular secretions. It causes constriction of the pupil. Okay, sympathetics dilation. This causes constriction, and this increases convexity of the lens. Okay, of the lens of the eye. Voiding of bowel and bladder. It's important for, and then also sympathetic was for ejaculation. Plays a bigger role in ejaculation, where parasympathetic plays a larger role in erection of sexual organs, both for male penis or clitoris in the female. Damage to the autonomic nervous system. So what happens when we have damage to the autonomic nervous system? So if we have like a spinal cord injury where we block or lose all control from higher centers of our sympathetic nervous system and some of our parasympathetic nervous system, S2 to S4, get the thing called initial loss of sympathetic tone. So somebody who comes in who's got a cervical spinal cord injury, when you first see them, they lose sympathetic tone, which means, remember that background vasoconstriction and that control to blood supply to organs that sympathetic nervous system is so important for? You'll lose a lot of that initially. So they really struggle with blood pressure or any kind of position changes. And that's your biggest hurdle, usually for the first few days to few weeks, to get somebody upright again after a major dysfunction such as a cervical spinal cord injury, which basically, eliminates the communication from the higher centers to your, so all those spinal cord reflexes that occur, there's an initial loss of tone. It just kind of, everything goes floppy or low tone. Even the body does too, the muscles do too, this kind of state of we call neurogenic shock or neurologic shock. The system doesn't know what to do and it has to kind of reset itself. But initially it just kind of shuts down, so you get this loss of sympathetic tone. Eventually your body compensates for it. Even if you have a complete spinal cord injury, your nerves learn to say, oh, I'm no longer getting this input from above. I better ramp up more normal. Plus your adrenal medulla starts to secrete more basal amounts of epinephrine. And that's the way you can raise up your basic levels of sympathetic tone and vascular tone through this means of more epinephrine being secreted from your adrenal medulla, since you're not getting as much, drive from the segmental level T1 to L2 segmental levels of control. Okay, so that's how. And then eventually you can sit them up. They can make position changes, but it's still never perfect. You can't get them up real fast. Still, you might have to take a little more time. And a lot of your spinal cord injury patients will continue to complain of difficulty with temperature regulation, with changes in body position. They have to make sure they're hydrated, and all those other things have to be, going right for them to not have problems. If you damage a peripheral nerve, okay, so you damage median nerve or something like that and really severely damage it, okay, you again loss of sympathetic efferents will cause loss of vascular control. So if you've got a big peripheral nerve you've damaged, you can get loss of vascular control and vascular tone. The area might look kind of swelled up because you lose that background vasoconstriction. It may look a little reddened. You lose temperature regulation in that area because you can't drive your sweat glands. You can't constrict blood vessels or dilate them very well. You lose sweating in that area, so it gets dry. And we call these trophic changes, where you get this combination of the skin looks dry, flaking, and red because over time you lose the normal secretions on your skin, both glandular and sweat, so you don't even have the normal oils and so forth. So the skin looks really kind of dry, shiny, red because there's blood pooling in the area, and that's some sympathetic changes occurred with just like a peripheral nerve injury. If you, damage a big peripheral nerve to a limb, like people who get these brachial plexus avulsion injuries, where their peripheral nerves are basically torn out, their limb gets very swollen, red, and dry, flaky because they lose autonomic. They're losing sensory motor plus autonomic control to that limb. Spinal cord, we just mentioned it, but if the lesion is above T6 versus below T6, that's where you have kind of the cutoff here, where if your lesion is below T6, you still have enough control of autonomic function of your upper body and also of your heart. That's where the regulation for your heart, for your sympathetic control of your heart, is above T6. Those are intact enough that you can make changes to enough percentage of your body surface and vessels in your body, and also drive your heart rate responses to accommodate, even though you've lost some of the control lower than that. However, if your injury is even higher, now you've lost any decent control of your heart rate and so forth, and also you've lost most of the huge percentage of your vascular control, then it's much harder to deal with changes in position changes and so forth. And then we'll get to this thing called autonomic dysreflexia, where you basically have enough of your sympathetic nervous system goes haywire, where you get this increase in sympathetic tone in response to typically painful or noxious stimuli. Okay, usually a full bladder or a pressure ulcer will cause nociceptors to kick in, and all of a sudden your sympathetic control at the spinal cord level reflexes, they turn up all of a sudden, and you can't turn them down because you no longer have the connection coming down. So this is haywire sympathetic reflex response. And we'll get into more detail when we get into spinal cord damage. Damage to the brainstem. Just know that any damage to the brainstem, you can have problems with autonomic control, okay, dysfunction, heart rate, respiratory centers, blood pressure, cranial nerves, thoracic and abdominal viscera. So patients who have brain damage or brain trauma that also impacts the brain stem, you could see a wide range of cardiac, blood pressure, respiratory issues that you're going to have to monitor closely. Cerebrum, okay, damage of cerebrum. Obviously, if you damage the hypothalamus, if you get a tumor in the hypothalamus or something like that, that's going to impact could impact touching lots of different autonomic system function. Regulation of homeostasis, metabolic disorders, obesity, anorexia, temperature regulation, all can be impacted with any damage to the hypothalamus. If you have somebody who has a lot of swelling in their brain, that will cause pressure to the center of the brain. Your hypothalamus is located right kind of in the center there, so that can lead to just general dysfunction of the hypothalamus. Last slide. So how do you, as a physical therapist, assess autonomic function? These are how we do it. Basically, you're going to be taking heart rates on patients, seeing how they respond to different changes in position, to exercise, so forth, blood pressure, okay? Specifically, if you look at blood pressure and heart rate, supine to standing is something you'll do with your patients, especially if they've been bedridden a long time or they've got a spinal cord injury. If you see a greater than a 30 millimeter mercury drop in systolic pressure and or a greater than 15 millimeter drop in diastolic blood pressure from a sitting or supine to a standing position, that's could be indicative of orthostatic hypotension. If it drops, if you see that big of a drop in blood pressure, either systolic and or diastolic, that's a concern. They could pass out on you, and that could be an issue for them. So you want to look into that. Respiratory rate, checking respiratory rate can be helpful. And then also skin inspection, looking for those trophic changes that you might see with somebody who's got a peripheral nerve damage or a large area of skin that's been deinnervated or a limb that's been deinnervated from autonomic control. Okay, so those are the things you're going to look at. So we're done. Any questions? We'll do a quiz on Friday. Motor system, is that what it is? I think we're on motor system on Friday. First motor system part 1.